And I'll go ahead and start introductions, or? Okay, sounds great. So I'm going to invite up our panelists for this afternoon talking about pain, Dr. DeForia Lane. I'll welcome her to come up front. She designed and implemented the first music therapy program at the University Hospital's Cleveland Medical Center. She's now retired, but she presents and consults with universities and hospitals across the United States and around the world. Dr. Matt Baer, if you'll come forward. He's a general internist and primary care provider at the Indianapolis VA Medical Center. He's also a core investigator at the VA Center for Health Informatics and Communication and a professor of medicine at Indiana University School of Medicine. Dr. Maya Story, she is also a core investigator at the VA Center for Health Information and Communication. And her training is in music therapy with a postdoc in health informatics. And Sam Rogers-Melnick, he is a music therapist and integrative health research and data specialist who focuses on investigating the effectiveness of integrative therapies at University Hospitals Connor Whole Health. So welcome, and we're excited and so pleased to have this opportunity to be in conversation with you today. So let me start my timer and I will get us started. So when our panel first got together and we started thinking about how we might approach the topic, and we knew that we were going to follow the performance of Inkling, I wanted to learn more about the performance and ran across this quote from Enrique Vargas. And he said in this article, he was quoted as saying, "Experiencing music combines most, if not all, of your senses and unique personal life experiences. Therefore, music is experienced not in one specific part of the brain, but as the interactions of various unique areas of time." And what our panel found particularly striking is that if you substitute the word pain for music, there we go, it speaks to pain as well. And when we're talking about, and it disappeared. Let's try that again. If you substitute the word pain for music, and when we think about using music to manage chronic pain, this also makes sense, that experiencing pain combines most, if not all, of your senses and unique personal life experiences. And therefore, pain is experienced not in one part of the brain, but as the interactions of various unique areas of time. So during this time together, we're going to explore the complexities of chronic pain, limitations of pharmacologic treatment, and research that's investigating uses of music to manage pain. And we're going to start off today with DeForia. So I pass it on to you.
Some of life's greatest lessons are learned from the people we serve. Clients, friends, family. I'd like to tell you about my favorite patient and the lessons learned from her. She was born in 1924. In the very deep South. That would make her 96, 97, 98 this year. People are complex. That was one of her lessons. Have we not heard that today? And so is their pain. She was one of 7 siblings, born in the Depression time in Atlanta, but she and her 6 siblings and her mother and father lost their house and had to move in a very rural, back in the woods part of Georgia with the mother's father. All of the children. She felt the pain of poverty, racism, and the mentality of staying in your place. She was very quiet, shy, observant, but she had some inner strength that I began to learn, and resilience beyond compare. She graduated, however, from Spelman College with a major in biology. Both parents had died by this time, could not see that process. Her mother with a stroke, her father, she told me, with a cardiac arrest. But they had encouraged her along the way to play the piano. She practiced at the church that her uncle pastored, and she took lessons. Somehow her parents gave her $1 to take one lesson 1 week after another. She learned to play Chopin, Rachmaninoff, Debussy. I heard her play Clair de Lune. And her other side of music was deep in her soul: gospel music, spirituals, and hymns. They were in her DNA. She migrated to Dayton, Ohio, and was hired by Wright-Patterson Air Force Base, where she became a digital computer clerk with those punch cards, Hidden Figures. If any of you have seen that, that was her. My first contact with her as a patient came many years later, when she was in her late 50s. She had inherited her parents' DNA. She had a cardiac arrest. They revived her, but she could not sleep. As a newly graduated music therapist, I had been taught the power of entrainment, of tempo, and relevance of music that's meaningful to the person. Now, I can't recall the exact song that I sang to her, but it was clear that her doctors were very concerned that she could not sleep. So, knowing some of her background, I believe the song may have been, "There is a balm in Gilead to make the wounded whole. There is a balm in Gilead to heal the sin-sick soul." Much to my surprise, within less than 2 minutes, she was snoring. Now, what I failed to tell you was I was just as surprised as anyone there. But not only was she my first patient hospitalized, but she was also my mother. So when I told her about, "Mom, I've been learning about how," "Okay, daughter, go ahead, you sing, honey, it's all right." You know, so when I did, and that happened, there was a confluence of here's my mom, but also the power of music. My mother also had a variety of comorbidities: congestive heart failure, chronic heart disease, glaucoma, osteoporosis, high blood pressure, stage 4 kidney disease, and periodic episodes of high anxiety and depression, some of which she had to be hospitalized. And at the tender age of 96, she felt a lump the size of an egg in her breast. Breast cancer at age 97. Give me a break, Ma. Why wait that long? And her words, daughter, she knew I worked in a hospital. No surgery, no radiation, no chemo. I'm too old and I've lived much too long. I've lived a good life. Just if they could give me a pill and make me comfortable so that I'm not in pain, I'm fine. Wanting to honor her, she said, I'm not going to a doctor. Now, I'd been working at the cancer center for 34 years. I knew what an untouched tumor could do to a breast. And I sure enough didn't want to see that in my mama, who was a 44 double D. So for a minute, maybe 2 days, I honored her request of no doctors. And then the daughter in me, the music therapist in me said, just before she went to bed, I said, excuse me, Mom, I gotta make a call. And I did. Call the doctor, come in tomorrow morning, DeForia, at 9:30. I said, okay. Went back to kiss my mama goodnight and do our ritual. And I said, oh, Ma, by the way, tomorrow morning, 9:30, we're going to take a trip to the doctor. Waited for the tornado and the tsunami, and all I heard was, daughter, you're tricky. That was okay. More than ever, I saw the gift of collaboration from that point, the need for sharing the load of living with a mother who had so many things and pain in so many different areas, not physical, but pain nonetheless. What I learned was, by embracing the expertise of all those around me, we were better together. Medication, Matt, shrank that tumor within 4 months. It was gone, y'all, an egg-shaped tumor. It was undetectable, and the navigation of the nurse practitioner, the urologist who worked with her kidneys, I can speak to the value of working together. So, even with a furry friend, Mom learned, okay, that's not the one, but that's okay, don't change it. Oh, okay. There were many ways that could be touching her pain. A music therapist and her daughter, there was a quiet, intense storm of anxiety brewing in both of us. I not knowing what lay ahead, and we accessed, Maya, all the resources we could. Medical, social, emotional, spiritual support. And the music, Mom had grown up, as I mentioned, in the Deep South. And the hymns and the spirituals and the gospel songs we had right there in the house. After all her appointments, and there were many, and follow-up tests, prescriptions, diagnostics, the insurance matters, all that waiting in between times were deafening. And when there were no more words or calls to make, there was the music. To quell the anxiety and worry, together we would sit in the living room, I at the piano, she beside me, and I would go through that hymnal one after another. Showers of blessings. There's a balm in Gilead. No, never alone. It is well with my soul. And she'd be transported back to that country church in Georgia, and her beloved chapel at Spelman College. She was a member of a church in Dayton for over 70 years. Each song held something for her, and the lyrics would represent where she was, her state of mind: resolve, assurance, rest, trust, peace, and we longed for all of those. So here is the lesson. In spite of the effective medications, the flawless kidney stent that was placed in her kidney, we couldn't have asked for more or better results in anything, but yet the depression and the anxiety escalated. Delusions, ruminations, tremors, and she repeatedly would say, "Daughter, I'm just too weak. I'm just too weak." Fear loomed large, and in spite of positive outcomes, the abundant resources, and the effective medication, we were still in a peak, in a storm. I found myself in desperation saying, "Mom, what do you want me to do?" And she couldn't answer because she knew there was none. And my need to fix it, find the answer, and apply the proper music therapy technique, searching, clamoring, but like my mother's silence, I knew there was nothing more to do. The music was there to carry us through the waiting, her living, and the coda. Like a symphony, each personal and professional provider played his part. That's what I compare what we do as a symphony. We don't all play at once, only when the score is indicated. Sometimes we're solo, center stage. Sometimes co-creating, improvising. Moments of harmony, silence, and the rests. Find and look for your place in the symphony. It will change. You may be first chair, you may be conductor, you may simply be listener. Whatever it is, find it, and the symphony will be one of grace. I'm not going to sing it. I'm going to tell you what the words are. My mother, because I don't think I can make it, but I will listen. My mother and I were on our way to the clinic for her Coumadin test. We got to the end of my block. That was it. She wanted to die without pain, without a long, lingering time, and she wanted to be with family. She got all three. I remember reaching over, "Ma," and I just did a quick touch of the wrist, and there was no more life there, and I knew it. There was no panic, there was no music, but there was peace. I turned the car around, went back home, called 911, and within moments, they were there. Where was the music, you ask? It was later. I heard the words of someone who knew what losing someone was like. And it served the purpose beautifully. The words are, "And just think of stepping on shore and finding it heaven, of touching a hand and finding it God's, of breathing new air and finding it celestial, of waking the sorrow and the soaring, they do coexist.
Thank you, Deforia. Okay, so Matt. Yeah, so Matt, before we go to having you talk a little bit, I'll just ask the group in like 1 or 2 sentences as we transitioned into this next part. What would you say is the greatest challenge that we face today treating chronic pain? And we're going to get into a deep discussion, but like in 1 to 2 sentences, what do you think is one of the greatest challenges that we face? Sam?
We have more data on intensity, feeling, simple pre-post one session rather than clinically meaningful outcomes of how you're functioning with chronic pain.
Thanks. Maya?
I think one of the biggest challenges is the complexity of chronic pain and the individual, a theme that we've heard a lot of today in different scenarios, but I think that's something that's going to be difficult to tease out.
Yeah. Deforia, do you have anything to add?
Sitting at the table with people like you, hearing your language and ours, and knowing that we're really in the same space, and now trying to make it work for everyone's advantage. That's the hardest part.
And Matt, I know you're going to talk more about these challenges, but can you talk a little bit more about what we know and what we don't know about the impact of chronic pain? And I'll hand this to you so you can do your slides.
Sure. First, I just want to say how grateful I am to be here and with this panel. I've never had such quite a sensory experience as I've had at this conference, and at a panel where I actually started to tear up. So it's quite an experience, quite an act to follow. So I do want to just provide some background, about chronic pain in the United States, how common it is. It's incredibly common. And according to the Institute of Medicine Sentinel report back in 2012, 2011, 100 million U.S. adults had, so 1 in 3 Americans have chronic pain. And just by way of context, if we compare chronic pain to other chronic diseases, that's more than diabetes, heart disease, and cancer combined. So it's incredibly common. This is the Institute of Medicine report that I alluded to, and it talked about how costly. So it's common, it's incredibly common. So when we're writing grant applications, we of course need to prove how significant chronic pain is, and so the commonness, the costliness, and that it's very disabling. Chronic pain is the most common cause of long-term disability worldwide. It's also, this is a simplistic picture of how comorbid chronic pain is, that often it's not chronic pain alone, it's often comorbid with psychological conditions. And the most studied is chronic pain and depression, where the overlap might be as strong as, depending on the study and the setting, 30 to 60%, where there's an overlap between chronic pain and depression. And this is somewhat simplistic even, because often people don't have just depression, they also have anxiety as well, or they have sleep issues as well, PTSD. So it becomes even more complex. And it's sort of, as Maya was saying, it complicates the treatment when they have these comorbidities. And I think for the best treatment, we need to address this comorbidity. And often in our studies and clinically, we don't always address that comorbidity. But I think music therapy has the potential and promise to address all that comorbidity. So that's just an overview. I was inspired by Kevin's comments about P. The people I've seen, the veterans I see in the VA clinic have inspired me over the years to be a better doctor, be a better researcher. And so these are, some quotes that veterans have told me, Doc, I hurt 24/7, sort of this ubiquitousness of chronic pain. It's with them all the time. I can't do anything because of my pain, so it's very disabling, which I think, speaks to, with this quote especially. there's some degree of frustration. Nothing works for my pain. I've tried multiple treatments, and they get frustrated with me. I get frustrated because we're not finding success. So we need new treatments and combination treatments to try and help this frustration. This kind of speaks to some of the psychological, especially depression, and in one of our talks, we talked about suicidal ideation. So on a scale of 0 to 10, my pain is at 20. If I don't get relief fast, I'm going to blow my head off. Very dramatic patient that I saw, but it just speaks to the psychological comorbidity and how it can actually be life-threatening. Another patient I saw was, I'd asked them, have you had thoughts of hurting or harming yourself? And said, Doc, I don't have thoughts of hurting myself, but I have thoughts of hurting others. So it's also not only suicidal, but can be chronic pain is associated with homicidal thoughts and hurting others. And tremendous anger can be associated. So I had a veteran tell me, if you take my hydrocodone away, an opiate, you might as well put the nails in my coffin. And so this speaks to, the veteran had a strong belief in this opiate medication and really feeling somewhat desperate if I talked about taking away that treatment, which we know has some well-known side effects and even concerning adverse effects of misuse, abuse, overdose, and even addiction. So I think our overall goal, to pain treatment is we really want to reduce the burden and the suffering. I mean, we see it all the time, how much our patients suffer with chronic pain and how we can intervene to reduce that pain and suffering. So in terms of pain treatment outcomes, we have numerous chronic pain treatments. But all those treatments are fairly modest. There's no clear winner in all our chronic pain treatments. And that all that evidence is, if rated methodologically, it's low to moderate strength of evidence. So I'm excited about the field and music therapy interventions and working with colleagues like Dr. Rob and Dr. Story, finding better ways to treat chronic pain, especially for veterans that I see in my clinic and in my research studies. So thank you.
Thank you. Yeah, and I think we're going to flip the order because as you were talking, Matt, about your work with patients with chronic pain, one of the wonderful things about Dr. Baer is that he's so collaborative in working with a lot of integrative health therapies, and Maya and I were lucky enough to be able to work with you. So I'm wondering if we can transition to Maya, and can you talk a little bit about the research that you're doing, in particular PTSD as a comorbidity, and can you talk about how your research with veterans and the importance of developing these inter and external resources as a way to help manage chronic pain through music?
Sure. I just have to take a second to readjust my future since I thought I was going last. So.
Oh, you know what? Let's.
No. I'm kidding.
Well, your
I'm really ready.
Your slides
aren't
in
not
order.
next.
So, moderator's fault. Well, we're going to go over to Sam. I'm sorry, I couldn't.
Unless you want to use my slides, and I'll use yours. That would be really interesting.
No, so we're going to transition over to Sam.
Hey, everybody.
And like we originally planned before Sherry thought she could do improv. But can you say more about the complexities of pain for individuals who are living with sickle cell disease? So Matt's been talking about, I know you do musculoskeletal pain. Sam has done a lot of work with patients who have sickle cell disease, and talk about like the factors that we need to take into account when you're using music interventions for pain.
Yeah, so patients with sickle cell disease face a multitude of painful conditions that derive not only from a difference in their hemoglobin, but also the discrimination, the disparities they face in the healthcare system. Biologically, if you go into the red blood cell of a patient with sickle cell disease, the hemoglobin, which job is to carry oxygen throughout the body, when it drops its oxygen, it can chain up with the other hemoglobins inside that red blood cell. That stretches that red blood cell out. It turns into that C-shape or sickle shape that they observed in a microscope 100 years ago. When it gets clogged up with the other sickle cells, it leads to this vaso-occlusive crisis. They call it a pain crisis, which leads to an overwhelming, inflammatory, nociceptive cascade. 7+ out of 10 on the numeric rating scale, which of course is a woefully insufficient way of describing pain in this population, so I will let a patient I work with describe it better. This was a patient in an art therapy session drawing what a pain crisis feels like. I think you'll notice shattered glass in the chest, which could be an experience of acute chest syndrome, which could be life-threatening. A punching bag and razor blades in the abdomen, fire in the legs, and different kind of pain, the shooting electricity, pins and needles in the arms. And this is a genetic disease. Patients started having crises 6 months age. Happens again at a year, 2 years, 3 years, 4 years. And over time, these crises can do collective damage to the body. So now your bones are starting to wear. You can have avascular necrosis. I've seen patients who have had to have hip replacements at 16, 17 years old. Now you've got this bone pain, and you've got this nerve pain because your nerves have been changed by repeated onslaught of crises. And both those types of pain do not respond well to opioids. As well, these patients, when you've had pain over and over again, it still hurts so bad. But the face that you present, it's not the face that you expect. You're not triggering a 7 out of 10 on the FLAC scale, but you're in so much pain. But you'll be told in the emergency room, well, you don't look like you're in that much pain. Oh, I can't give you that pain medication. Oh, your labs look good. And these patients face a lot of discrimination in the health system. They're called sicklers. They're called drug seekers because they have such high tolerance to opioid medication. And an appropriate dose is a very high dose because that's the kind of pain they're dealing with. And over again, they have these experiences. Now coming to the hospital is a very stressful experience. And that lack of trust leads to lack of adherence. It leads to tension in the health system, and that perceived discrimination through several research studies have shown that makes the pain even worse that these patients deal with. As well as the structural racism, they can't afford the copay to go to acupuncture, go to these really comprehensive pain management centers. And so this is a population I started working with a decade ago when I came to be an intern with Euphoria Lane University Hospitals. And one of my supervisors has this idea, let's do a group drumming session for adults with sickle cell disease admitted for pain crises on the medical oncology floor. And we invite these patients down. We had to build trust, go in the morning, working with them. And I noticed 30 to 60 minutes of group drumming, singing, songwriting, interacting. The more patients engage with the music, the more they're reporting a reduction in pain intensity, but also better relationships with the staff and the nurses where there's so much tension. And so that also provided an opportunity to build trust with this population, which led to future research. So now 2 years down the road, DeForia Lane thought it'd be a great idea that I could be a principal investigator on a randomized control trial, mixed methods, comparing music therapy versus music listening for control. And one of the challenges there was, how do you take active music making, all these things that happen, this whole brain experience, and put it in a nice little research-sized box, right? So I'm gonna try to demonstrate on I wonder if you could hold this microphone for me. So we would create 20-minute music interventions, always the same template, but personalized to genre. I'd have a set of headphones. The patient would have a set of headphones. It would kind of look like this. And we'd have a little musical conversation. I'd say something. Well, let's put that sustain on. Patient might say something back. No prior musical training needed. And the gospel intervention would kind of sound like this. And over time, patients will get more creative. We go back and forth. See the affect change, see the behavior change. And so that's an example, as people were asking before, how do you try to put some structure for a trial, thank you very much, around those kinds of things. And in this study, we noticed there were significant odds of having a clinically significant reduction in pain intensity, improvement in mood compared to control. We didn't see the same reduction in the music listening group. And patients described, the music helped me, it put me in a better mind state. Instead of thinking I'm in agony in the hospital, it was more soothing, like I'm at home just relaxing. And there was something important about that therapeutic relationship. Dr. Bratt talked about that earlier as well, and sort of setting the tone, helping to engage the patient in the intervention. But moving beyond that, it's not sufficient that one 20-minute music intervention can address acute pain. These patients have pain every day. And so even before I got to a study that could look at that, we need to ask the question, well, how are these patients using music at home? And if you looked at the literature, what the literature said about music for pain, it should be orchestral. It should be nice and slow and chilled out. These patients listen to hip hop, they listen to R&B, they listen to something with an 808 beat to it, they listen to something with high bass, right? And it's something you should know, but it needed to be documented as well. We also asked the question, when you listen to music to help with pain, what do you do as well? Do you sing? Do you pray? Do you lie down? Do you move? And the more strategies patients used along with music listening at home, the more benefit they found in pain reduction. And so we had to take all these things into consideration. What do you even have at home? Do you have a smartphone? How am I going to make this intervention accessible to a population that has really a lot of difficulties getting down to the hospital, might not even have a private space at home to listen to music? We ended up creating an intervention. It was 6 sessions with patients with sickle cell disease and chronic pain. First session was all about building trust, understanding how music can address the body. We built this model with lights to explain the gate control theory of pain. We set goals. What's important to you? It wasn't a reduction in pain intensity. It was, I want to be able to play with my kids. I want to be able to have enough energy throughout the day. And the next several sessions were focused on practical exercises, right? So patients were making beats with me. Let's make a beat that's really personalized to you. Then we can do a guided breathing exercise. And I'll record it in real time in my fancy studio over here. I'll cut that track, I'll put it on your phone, and you can practice it as a practical skill. We can do the same thing with imagery. Let's go to the place. What does it look like? What does it smell like? What does it feel like? Let's create all those sounds together in this personalized experience. It's the same thing with progressive muscle relaxation, as well as teaching them this exercise I just showed you. And we found in this study significant improvements in self-efficacy and reductions in pain interference. As Dr. Pratt said, those are very linked and very important, having that confidence to manage your sickle cell disease pain, as well as reductions in sleep disturbance and improvements in ability to participate in social roles and activities. Beyond that, patients talked about, and we see this, takes my mind off the pain, puts me in a new dimension. Those couple of minutes I don't hurt, I'll be in a whole other world. I think that's sort of the basic level of what music does in pain, this refocusing element. But there's also how we support and how we manage the emotions around pain, or even transform your relationship to pain. When I use some of these techniques, I can handle the pain a little better than usual. It had an impact on my ability to cope with pain. So let's get beyond intensity. Let's talk about functioning, what you can do in your day-to-day life with these skills. And once you start learning to manage things yourself, doing things becomes easier. I'm able to do chores because I'm listening and I'm breathing. So let's make music therapy a practical exercise these patients can use to address quality of life.
Thank you. Okay, now we will transition to Maya. And Maya, can you talk a little bit more about the research that you're doing with veterans?
Yes, I'm ready now. I'm sorry your improvisation didn't work, because that would have been cool too. One of the interventions that I use and that we're researching is using music and imagery. And I just want to say right away, and I'll talk more about it later, that it is a very engaged way of listening to music. So I think we often think of listening to music as passive, but there are very engaged, deep listening experiences that are engaging imagery and memory and all kinds of other things that are going on. This is an image from a New York Times article that was about chronic pain and using art to process it. And because of my interest in imagery, I just found it really strong and evocative. And she says that in the fall of 2000, I developed severe chronic facial pain. This domination of pain obliterated all sense of an inner self. And you can read the rest. But it was that obliterated all sense of an inner self that I really resonated with in the patients that I've worked with as well. My first research with music imagery was with veteran women who had experienced PTSD and military sexual trauma. And there was a lot about sort of having to reconnect with their self and their identity and how their identity had changed, being in the military and then coming back as civilians and then processing the trauma that they had experienced as well. And I think, again, that speaks to the complexity of the individuals that we're working with. And I don't want to pigeonhole veterans as being a certain way, because veterans are as varied as civilians are in terms of what they're, how they are, the personalities, what they need, how complex they are. But there are some things that we see in common, and there is a high comorbidity, a high incidence of PTSD in the people in our studies with chronic pain. We're seeing that. There are issues of isolation, because reintegrating back into civilian life is difficult when you come back from the military. So that, in addition to dealing with the chronic pain, can cause them to self-isolate. There are relationship issues and social support issues that are caused by living and dealing with chronic pain that make relationships strained and difficult. So those are some of the complex things that we're working with. So I'm using music and imagery, and those of you that are music therapists, this came out of the Bonnie method of guided imagery in music. So it's a method that uses, it's a little misleading because it says guided imagery, but we don't actually guide the image at all. The images come from the music itself, and the role of the therapist is to help the patient focus and enhance those images and help them stay with those images. And so the images speak at its most complex form. You're very open to what comes up, and the images help you process the things that you might be dealing with in your regular life. So we use a lot of metaphor and analogy to do that work. But we've modified it so that it's much more accessible to clinical populations. And one way that we do it in the current study that we're doing is we're looking at a very supportive use of music and imagery. And I should also say that the Bonnie method uses Western classical music, and we're starting to shift away from that. But with the music imagery work that we do, we're actually using the participants' music. So we're starting with those things like the hip hop or the whatever it is that they listen to, realizing that we as the expert music therapists don't necessarily know what is going to be relaxing or triggering for the individual. So I just want to share with you one experience that I like, showing how we choose music with an individual. And this is at the very beginning stages. What we're teaching them is how to use music to regulate, because a lot of veterans and people listen to music all the time and don't realize that something's happening as they're listening to music. So how to be aware of that, how to listen deeply to your music, how to make good choices about what to listen to is something that we work on with them at the very beginning stages before we then move into working more with using music to help enhance inner resources, which is the resources part I didn't get to yet. But so I worked with one of the participants in our study. We started with a check-in, and he said that he was experiencing some moderate pain. We also checked in about his feelings and his thoughts around that. There were a lot of stuff going on in the world at that time connected to social injustice that were very close to him in his community. But he wanted to focus on the moderate pain. So I asked him for an image of that pain and how he was working with managing that pain. And he gave me the image of a bridge and the idea of a bridge being built. And he could kind of like see it in slow motion and also see it in fast motion, the idea of like one piece being built at a time, and the community and the number of people that it takes to help build that bridge. It was a really interesting image. So I said, well, let's find some music that matches that image or that feeling. So he first chose this song. Well, there's the image of the bridge. Let's see if this works. Oh, no. I know.
I don't know if from the computer if you can find the buttons, and maybe they aren't there anymore.
Do you see on the computer a little
any
sound image?
No.
That's too bad.
Sorry, Maya.
I wish I could sing it, but they're instrumental. And I don't know why that started all over again, but we don't want that image while I'm talking, though, so let's go back to there. So I'll have to describe it. The first piece was this very meditative sort of instrumental piece. And he said that he could imagine himself doing like some slow Tai Chi or martial arts to the piece. It felt very relaxing, very what we think would be relaxing music and the people might choose to relax to. So that was good. And he was really able to connect with that. And I said, because we often do ask them to then choose another piece, because we think of it as as the musical pieces as bringing friends into the room. So you might have a couple different musical pieces that represent different friends you want in the room, and they're all going to be helpful, but which one is the most helpful to you at this moment for what you need to connect with? So the next piece that he picked was the theme song from the Transformers movie. And I don't know if any of you know that, but it's got like this strong rock beat. It's very fast, it's loud, and it's called, it's from the Transformers movie, so there was this theme of transformation in it too. But we listened to that together, and he said, after listening to it, he said, I feel so much motivation, and like motivation to move and to work with my pain and to be able to do the things that I want to do. And he said, pain doesn't have to be your centerpiece. And he said, pain does not have to be my centerpiece. And like he really owned it. And so that was just an example of two really different types of music that were both helpful to him, but in that moment, he connected with and needed that second type of music. And so then just briefly about resources. I think it's really important to build up the individual's inner resources, so that it maybe has to do with resilience, but it's that ability for them to feel their power or feel empowered, their ability to be calm, to regulate, self-efficacy. All those things are kind of characteristics that they have internally, but maybe they don't know how to access them. So it's about using music and imagery to help enhance those and connect them to those. And then the external resources are so important too. So the community, the symphony of beings that DeForia was talking about in terms of their care, but also connecting them to their local community. And music is another way that we do that. And we can use the local musicians and programs that maybe they don't need music therapy for that, but to connect them with the local organizations that can help them connect with others musically and continue that sort of healing in a different way.
Thank you, Maya. So, one of the questions that we had when we met, getting ready for today, was an interesting conversation before we open it up to Q&A to the group. And one of the things we talked about, because it's one of the questions that we as music therapists often get asked, Matt, I don't know if you get asked this question about integrative therapies, but it's, what's the status of how do you pay for those therapies? How do you make that a sustainable service? How do you increase access to service? So I thought maybe each one of us could maybe talk about what is the role that research plays in terms of increasing access to service, and is the answer third-party reimbursement? Is it bundled models of care? Is it something else?
I don't know. Short answer, I don't know. Yeah, I think, so working in the VA healthcare system, I don't have to worry about reimbursement as much, and we're very fortunate to have access to a lot of these complementary integrative health treatments for our veterans, including music therapy, which is fantastic. So my approach for studying is looking at different modes of delivery, and so either technology delivered or virtual delivered. And so Sherry, Maya, and I are working on a virtual delivery of 2 different music therapy interventions for veterans, so we can capture them in the home. So you're addressing not only urban dwelling veterans, but rural dwelling, so you increase access to these evidence-based treatments to rural veterans.
Yeah, so I think policy is not always driven by good data. Like, we decided to give everybody opioids because one guy wrote a paragraph that says less than 1% of people get addicted to opioids, right? Policy is driven by politics, which is driven by power, which when wielded responsibly is driven by good data. And so I think, my role now at UH is let's get data about music therapy in the real world. Tens of thousands of sessions every year. What's the effect on pain intensity? Those hospitals are now incentivized. It's very slow, moving from fee-for-service to value-based care. Because even if we just took what we're doing now and let's get music therapy reimbursed, it's not going to be the substantive change that we need. Well, what kind of insurance do you need? Can you access it? Are there enough music therapists? But hospitals now are incentivized, rather than saying, well, just give everybody opioids, well, here's a certain set of money, and you want to manage pain in the best way possible. And so let's build your team out. And music therapy is on that team. That's highly effective. Maybe acupuncture, maybe massage therapy. And in the outpatient world, there's a lot of great models, the VA being one of them, Vermont being another one, about team-based, comprehensive, integrative pain management, looking at functional outcomes. And most of the research has been in acupuncture, it's been chiropractic. And music therapy can get there in terms of our impact on people's capacity to function. And once it's there, and we're at the table with the insurance companies, and they see that, and they can see how the model works, it's got to shift from, well, just this one service, just that service, to we want to pay for a team-based approach that's patient-centered and data-driven.
I'll just briefly say, my first experience seeing a doctor's wife or seeing another doctor's mother as a music therapist, they never turned away again. They looked for me, and I couldn't have done that if it hadn't been for their experiencing it personally. I didn't have a lot of folks like Matt. I mean, that would have been my cat's meow. But when they saw what it did for their mom or their wife or their child, good gracious alive, that was it. So I think part of it, I can look at Dr. Lim. He's got a heart for this, and he's got this stuff up here too. When you get those two things together, that's not scientific, but it's true, y'all.
Did you have anything? Okay. All right. And we also wanted to make sure we saved enough time. I think we have at least 5 minutes. Is that right? To open it up to a conversation with you as well, to see what you're interested in seeing or talking about in terms of pain.
With respect to the opioid issues, there are so many, it's a complex issue, obviously. I will tell you this, as a practicing surgeon, if I gave all of my post-op patients music therapy and no pain medicines, no pharmacologic, I'd probably lose my job. And so that's just sort of the flip side of things. And I'm not motivated by politics, I'm not incentivized in any way to do that. It's more my assessment of what that person needs, considering what I just did to their body.
Yeah, and I don't think probably any of us would advocate music as a substitute for pain medication. I think it's how can you combine music for pain management along with pharmaceutical medications. I think you can speak to it better than I can, Sam, but for some people, the opioids don't do enough, and there isn't enough research in sickle cell disease and pain management. They don't have good treatments for it, so it's, can you use it to help supplement that? Yeah. Yeah, and I'm so glad you touched on acute versus chronic pain. So one of the things that I think is important to acknowledge is there's a lot of research on music and acute pain, short-term pain that will eventually go away. And we have a large body of evidence on music listening and acute pain, and probably time to really synthesize that research well and find out some best practices and pragmatic trials. But your first question was about non-responders, which I think is really important, and I'll let the rest of the panel speak to this as well. Music doesn't do everything for all people, and I think a big part of the research that I'm doing now is figuring out for whom do certain interventions work and under what circumstances, because it doesn't work for everybody. And I have worked with patients who music wasn't a good option for them, and part of that is honoring That's empowering people and honoring people's choices of saying, I don't want this doesn't work well for me, and for me to stay in that situation and force it on somebody who's totally contrary to what you would be doing in the first place. And then the other thing I have seen is that I've also had patients, because I've had the blessing of working in settings where people are there for a long time, so acute burn treatment and rehabilitation. I've had patients who didn't want to have anything to do with music or me at one point in their treatment, but then at another point, it was something that they really needed, wanted, and were ready for. So I think it's also checking back in with people over time, because there are times in their life when they don't want or need that. They need something else. And so our job is to help people find the right supportive care that's right for them. Other people.
Great questions. And I guess practicing primary care, I think I have a primary care advantage. What that means, I've had a longitudinal relationship with my patients for 10, 15, even 20 years. So I can trial and error. And there in chronic pain management, there is a lot of trial and error. There is a lot of non-responder. There is a lot of tailoring. And so music therapy, like any other non-pharmacologic treatments, or any treatments for that matter, might help to some extent or not help at all. But that trial and error is very helpful. And I always want to give patients that hope, because they're deep in a hole, right? They have chronic pain, they're depressed, and they feel like this specialist has given up. I can't offer you, they get that message, I can't offer you anything. So I never want to give my patients that lack of hope, that there's always something we can try, and trial and error and hope.
Yeah, I think it goes back to that team management approach. I mean, it's an important question to ask, right? Like, who is going to respond best to what treatment? Sometimes being a music therapist in the medical center, you're not in that conversation. You're like, oh, well, this is a nice thing that we offer. Here's music therapy. You know, in the integrative oncology world, it was really nice. I had certain patients, they did not respond well pain-wise to me, but acupuncture did. And we would triage with each other. But I was better at addressing their anxiety. And so having that team-based approach, but even, what we're doing in Connor Whole Health and having this practice-based research with integrative health networks across the country, let's gather that data set so that it's not this like kitchen sink model. I'm gonna show up to a center, and I'll try acupuncture, I'll try this for my chronic back pain I've had for 15 years. We should have data that has more recommendations based on your demographics and your clinical condition and your prior experience, so that, not that everything is driven by data, but we can have more informed choices. We kind of need to change the equation about music therapy not just being this nice thing that works for everybody, but in more precision medicine, let's find out which patients respond best to this treatment or this different kind of music intervention versus other kinds of integrative health modalities. In response to the opioids, I would never say to replace them, especially in the surgical context, but it may help change your relationship to opioids afterwards. A lot of patients, there's studies about, you present to the emergency room, the more opioids you're given post that, the higher risk you have of having addiction because of that. Music therapy can help be that substitute when you're still managing pain post-surgically once you're out of the hospital.
I just want to say quickly, because it's interesting, that we often get an opposite version of that question, which is more like, nothing is working with this patient, so can you try music therapy? So they're non-responsive to everything else, and so let's try music as kind of the last resort. So it's very interesting to think of it from the other side. And again, it speaks to the complexity of the individual. There's a great study out of Norway, though, that I think Dr. Gold was on, that actually looked at non-responders with schizophrenia who then were enrolled in music therapy programs and the outcomes from that.
Do we have time for one more? Okay. Back. Yep.
Patients are continuing
Just thinking that in the current study that we're doing, we're looking at music imagery, but we're also looking at music listening after they have one session with the music therapist. And then we're having them keep logs of how much are they listening to music on their own and what are they experiencing on their own independently as they're listening to music. So I think that can give us some data about like how compliant are they with doing this on their own, and is it having any positive effects for them that they're feeling as positive effects. And then doing more, post measures where it's sometime after the treatment has stopped and seeing if there are still some effects is really important in our field as well, to check in about that compliance and how they've continued to integrate it into their lives or not.
Thank you so much.